there's a lot of us here who have never done this procedure before. I've done one myself, and I've participated in one. We can do this.
And it's sort of a procedure that you hope you never have to do or be a part of. But when indicated, we want to be ready for it. And so let's go through some of the equipment and things that we want to have ready should we get a couple minutes to prepare. So let's look at our tray here that's been prepared. Okay, I have some chlorhexidine for a splash prep of the abdomen. Now, if we have time to do this, fine. This should not delay starting the procedure. We want to do this as soon as possible. There's not good literature on this, but it should be within 4 minutes. So if this delays care, forget about it. Okay, now what else I have on my tray? Several times I got a scalpel. I have a 10-blade scalpel. 10 blade, doesn't matter. 11 blade, fine. Whatever blade,
15,
it doesn't matter. You just find a blade. We got some scissors. Now, preferably we want some sterile bandage scissors, okay? I have trauma shears. Fine, again, nothing that delays care. The important thing here, if we have it, is scissors that are blunt on one side and sharp on the other. I'm going to use this to open up the uterus. If you have a retractor.
The bladder retractor, yes.
Yes, if we have one, we're going to use it. If you don't have it, that's okay. We will still do the procedure.
You can use your hand to just move the bladder out of the way, but keep in mind that a very pregnant patient is going to come in with a very full bladder. You're not going to have time to decompress that bladder. So you're going to need something to get that out of your way.
Okay. And then we have clamps. You could use a delivery kit if you have one, or very simply, 2 clamps. This is how we're going to clamp and cut the cord. And then I have somewhere to place the placenta. I have sterile towels. Tarlin, how much of this do I need to have here before we do the procedure?
You basically just need the scalpel and your hands. You should not delay this procedure looking for instrumentation. A scalpel and your hands are really the only tools you need to get this done.
There's some suture on the tray as well. And so once we get to that portion where we're thinking about the post-hysterotomy resuscitation, we can talk about sutures. Medications, what do we want at the bedside?
Yeah, so if we have a little time and we know the patient is coming, there's a few things that you can ask your nurses to get for you. So 1, antibiotics. We're about to open up the patient and violate the normal protective skin barrier. So some antibiotics would be helpful in this scenario. And then thinking ahead to if we are able to resuscitate the mother, then perhaps getting some oxytocin ready for the patient immediately afterwards would be helpful as well.
Okay, so we have a quick pre-brief of the room, but it looks like our patient is
the patient's here.
Arriving already, and so it is go time right now.
Come on over, guys.
Okay, we want as many hands on deck as possible. So we would have a physician team at the head of the bed to manage the airway. We would have a team ready to focus on the resuscitation of the mother, and a team ready to receive the infant and do the neonatal resuscitation. I get to just focus on the procedure, which is stressful enough. When you're ready.
So for the purposes of the simulation, we are turning off the Lucas device.
Thank you.
But standard ACLS care should continue for the mother. We are going to now focus on the resuscitative hysterotomy.
Okay, so we've heard report, and the first thing I want to do, let's get hands-on. Do we feel a pulse? While you're doing a pulse check,
I do not feel a pulse.
Splash prep here. Okay, and the other thing I want to know is where is the fundus? My landmark is whether or not it's above the umbilicus, which it is, way above it. This suggests that the patient is beyond 20 weeks. So we have no pulse, and we have the fundus above the umbilicus. This procedure is indicated, and it's time to start. Okay, so I'm gonna take the scalpel, and I'm gonna make a long vertical incision right down the middle, starting at the fundus. In this case, that's all the way up near the xiphoid. And I'm gonna make my incision down, all the way down to pubic symphysis. Okay, you don't have to get through all the layers with one incision. There we go, thank you. Just like real life. Okay, so I'm through skin, and now I'm gonna go through, this looks like fat, soft tissue. Okay. Now what I'm seeing here is uterus. Pink bulging, smooth muscle of the uterus. So now let's get our retractor, and you're gonna help Ken retract this way, but we're gonna look for the bladder. We don't see a bladder on the simulation, but we wanna make sure we protect that. Okay, now I'm going to make my hysterotomy incision. I'm gonna look at this inferior portion of the uterus, and I'm gonna make a small incision here. And what I'm looking for is clear fluid.
We do always worry about a potential injury to the infant. However, the risk of that is exceptionally low, so about 1% in these procedures, in these resuscitative hysterotomies. So you want to be careful, but you are working quickly.
This was muscle, so I have to go deeper. There we go.
And there's your
it was not an
fluid.
abdomen yet. There we go, clear fluid gushing out. So there's my amniotic fluid. Make sure the muscle is fully exposed here. And that's great, and I have just a little bit of opening. I'm gonna go a little bit further because I need this to be big enough to get my fingers into. Watch your fingers, Tarlin. That is baby.
All right, so let's grab
So-
the scissors.
Now I've got 2 fingers inside the uterus, and I'm gonna lift up, and I'm going to take the scissors, and I'm gonna open the uterus the rest of the way.
To the cord. And that's it.
Okay, how big does this need to be? It needs to be big enough for me to get my hand in and bring the baby out. So I'm reaching my hand down,
I can provide some fundal pressure for you.
okay? And I have my hand, fingers open, my palm is on the baby's head. What I'm trying to do is lift the baby's head up out of the pelvis. And so I'm reaching down and lifting up, and as I do that, you're gonna give me fundal pressure. We're gonna make a ramp for the baby's head, which unfortunately I've lacerated.
That 1% data I gave you.
Fundal pressure. Okay, here we go. Baby's head is out. So I'm gonna sandwich the baby's head between my hands. I'm gonna deliver the anterior shoulder, and then I'm gonna deliver the posterior shoulder. And here's the baby. Okay. So let's get our nurse on stage to be ready to receive the infant. And we're gonna clamp this cord and start that neonatal resuscitation. So clamping here. You can grab that towel.
Nurse, can you hand me the towel, please?
Okay. We're gonna cut.
Boom.
Okay.
Put the baby on the towel.
Okay, and let's
All
get the baby
right.
to our neonatal.
And pass the baby off.
Okay.
Thank you.
Okay, now I'm gonna focus on the placenta, which is mostly out, and I'm gonna pull a little bit of traction here. It looks like the placenta has some damage as well, so we're gonna have to be mindful of that. I'm gonna give some traction, pull, placenta's out. We're gonna get this into the tray. I'm gonna do a sweep of the uterus, make sure I don't feel any retained placenta, and I don't. Okay, let's take a breath for a moment. It did not go perfectly, but we got the baby delivered.
We just did that.
We just did that.
Oh my God.
And we are not done.
No.
There is so much more to do, but what I wanna do is I wanna take a pause here, okay? We're gonna worry about this in a second, but why don't we pause here and bring Simon back out, and maybe the 2 of you could talk about the next steps in the post-hysterotomy resuscitation.
Will do.
So when we were thinking about allocating tasks for this one, you can see why I didn't volunteer to do that. That was an awesome display. That was absolutely fantastic. Well done, guys. So let's have a look, just while we're resetting, so let's just have a quick thing. So now there's always that thing with halo procedures sometimes. When you've done it, there's almost like you have to restart your resuscitation again, because baby's out.
Yeah.
We've still got mother there.
Yeah.
Baby's being looked after. So
Yes.
what are we doing from? What's in your mind now about how we optimize the ongoing resuscitation of mum?
Yeah.
Because she's got a pulse now.
Now she's got
You've
a
done
pulse.
a job.
Yes. And so now is where the hard work begins. So we sort of got through this horrifying procedure that we have to perform in the emergency department, and now we get to step back and now tackle the resuscitation of the mother. So now we have a pulse. We have to sort of tease through what led to this cardiac arrest. Why did this mother die in an out-of-hospital cardiac arrest that we had to resuscitate in the emergency
Yeah,
department?
so what sort of things are going through your mind now?
So sort of common things being common, the first thing that's going to be on my mind is going to be pulmonary embolism. So I'm going to be worried, did this mother suffer a pulmonary embolism that led to her cardiovascular collapse and then this halo procedure that we had to perform? Beyond that, if I'm going to try to look at her legs, they're probably going to be swollen. Most pregnant women who are later in their gestation are going to have very swollen legs. It may be hard for me to determine whether there's a deep vein thrombosis in there. Other things I'm thinking about, is there a pregnancy-induced cardiomyopathy that I'm dealing with? Or aortic dissection, exceptionally rare in pregnant women, but it happens, so I need to be thinking about that as well.
Yeah, or even something like an eclampsia, and they've had a hypoxic
Absolutely.
event, and they've come in. So the differentials are actually really quite broad, but I totally agree with you. The P's got to be bang up there on our top of our list, hasn't it? So she's going to need some diagnostics if we can get her to, if she survives long enough to get through
Correct.
the CT scanner and stuff like that.
Correct.
So that's really, so the diagnostic, you've got your brain working, and that's great. But we've also got to treat. So we've now got an open abdomen. There's lots of I normally say Clara, because we're in Spain, I was going to say there's lots of Rioja knocking around
Yes.
in here. There's lots of red stuff
There's
around,
lots
and
of
they're
red
bleeding
stuff.
lots. So how can we manage that, particularly from the uterine bleeding?
Yes. So a couple of things are happening simultaneously. So if I don't have obstetrics at my hospital, then you are looking to get this patient out of your emergency department as quickly as possible. So this is where now I am calling to try to transfer this patient out. It may not be me calling. I may delegate that task to someone else, but this patient needs to go. They need to find an obstetrician to care for this patient. So that's number one. Number two, now you're right, the abdomen is open, and I'm going to do my best to try to maintain this resuscitation since she now has pulses. So the first thing I'm going to want to do is take a quick look inside of the uterus and see if I see any active bleeding, any pulsatile bleeding, anything that I could either clamp or maybe tie off and try to stop that bleeding. The next thing you need to do is you need to pack the uterus, and you can pack it with just basic sterile towels. But in effect, we are trying to achieve a tamponade effect. So get those towels inside of that uterus so that you can tamponade the oozing that's going to be happening in there as well.
Yeah, and that tamponade and that pressure should help. You could use hemostatic dressings, although I know quite a lot of them are not really approved for use in that sort of setting, but if you had to, maybe, and you might even try a tacking suture just to put a bit of extra pressure on around, maybe you could do that. What do you think is going to go on with the clotting?
What's going to go on with clotting?
Clotting?
Well, I think we're probably going to be heading down the hypothermia DIC route. We always say that a patient that's bleeding, that's actually a good sign of resuscitation. So if I have a mother that I have just done this procedure on and I'm not seeing much bleeding, that's bad. Then they are not perfusing appropriately. But once you start to see bleeding, that means you have probably achieved your resuscitative efforts and you're going to try to maintain that.
Absolutely. And you did mention oxytocin.
Yes.
And there. When's the right time for that? Would you give it an arrest?
I would not give the oxytocin during arrest. So you definitely want to wait until you've got pulses, you've got some sort of a rhythm on the monitor or something that's hopefully perfusing, and that's when you want to give that oxytocin.
And that's 5 international units. Slowly. It can cause dysrhythmias, it can cause hypotension, which are not going to be your friend.
Yeah, we don't want dysrhythmias
We've just
or
done
hypotension
that. We've just
in
done
our
that. Let's not do it
patient
again.
now. Yes.
Brilliant. So there's an awful lot. That restart that resuscitation, look after the mother, and hopefully we're going to have a great outcome.
Yes.
We'll find out later.
Yeah.
That was a slow walk-through, talk-through.
Yes.
Jess is probably recovered now.
I hope so.
Do you think we should make her do it again in real
Let's
time?
make her do it again.
We could. So to try and demonstrate, the speed and the urgency, let's see if we can run through that again in real time and see what we get out of it. Should we do that? Do you want to go quick prep?
Let's do it.
Excellent. So I think our phone might ring.
Down. Down, 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 down.
This is
down,
Dr. Mason,
down,
emergency
down,
department.
Down.
Copy that. Okay. We are receiving a 28-year-old female, 3rd trimester pregnant. 3 minutes. Got it. We'll get ready. Thank you. Hey, Tarlin, can you join me? I'm going to need your help. Okay, I'm going to prep this while she's getting in some PPE here, because the patient is on their way, and quickly reviewing the equipment that I've got. once again, I've got my 10-blade scalpel. I've got bandage scissors, or in this case, trauma shears. I have a retractor. I have 2 clamps. Chlorhexidine if I'm going to splash prep. I got some suture, a towel to receive the baby, and something for the placenta. Thank you so much for joining me. On their way, basically right now.
Yep.
Looks like we're doing a resuscitative hysterotomy, so I have everything ready. If you will assist me.
Let's do it.
Okay.
Okay. Oh, the patient's here.
Okay, that was fast. Here we go.
We got a space right here for you guys.
We got CPR in progress. So first thing we're going to do, transfer the patient onto the gurney, and then we're going to do a pulse check.
All right.
Okay.
All right. Thank you.
See if you can feel a pulse while we
All
have
right.
that Lucas off. Do you
Nope.
have a pulse?
No pulse.
I don't have a pulse. Fundus, well
Above
above
the
the
umbilic.
umbilic. Okay, it's go time. We got to get this done as fast as possible. Okay, incision. Through skin. Through fat.
Uterus.
I believe that's a little deeper.
Oh, they're deeper. Mm-hmm. Okay.
There we go.
There we go.
Okay.
Okay.
I think that is peritoneum.
Yep. We're
Let's
in.
get the bladder retractor
Okay.
out of the way. It's a little hard to tell which layer. I think we're not in yet because we haven't seen the
Nope,
amniotic fluid. So probably this is going to be our hysterotomy incision right here. So I'm going to make my incision at the inferior end. And there's the amniotic fluid. Okay, so we're in. So 2 fingers in, lifting up. I've got my scissors, and I'm going to extend that incision superiorly. Okay, long enough for me to reach in. Ooh. Okay, that's the baby's head.
That's the PPE that we need there. I think
Oh, no.
You need to cut here.
A little bit deeper.
A little deeper. Cut through there.
Okay.
Use your scissors. This is very thin.
Yeah, that is thin. That's it. Okay, I see. Okay. Extending that incision superiorly and inferiorly.
And baby.
Okay.
Let me give you a
Get
little
ready for
fundal pressure.
Oh, head wants to come out. There's the head. And we're going for that anterior shoulder, if possible. Come on, baby. Anterior, posterior, baby's out. Baby's delivered.
All right.
Okay, hang on to that baby for me. I'm going to
Got
clamp
it.
the cord.
Yep.
I'm going to clamp.
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 I'm going to be passing the baby off to you in just one moment. Make sure that neonatal resuscitation team is ready. Cord is cut. Okay. Okay, try and warm that baby, please. Okay, now we're going to work on delivering the placenta.
Gentle traction.
Okay. I'm going to give it a little sweep here. This is why eye protection is important.
Yep.
Right?
There's the placenta.
Okay, placenta is out.
Out. Okay. Right. Jess.
Sweep. Okay, now let's work on resuscitating that mama.
Yeah, let's do it. I think I have a pulse.
You have a pulse.
Yeah.
Let's get that oxytocin.
Woo.
So well done again. I reckon that was under 2.5 minutes to complete the entire procedure and less than 2 minutes to get the baby out. And realistically, that's achievable. So well done, with a bit of practice and everything. So we've talked through this. We've talked through the halo procedure. We've done the psychomotor skills. We've talked about the periphery of the stuff. But it is worth reflecting, isn't it, with this particular procedure about why we're here.
And well, the goal here, what comes in is no one is alive. And the ultimate goal is to have 2 living patients at the end of this. And I also want to call out something that really is interesting in now doing this twice. I'm not a surgeon. And so cutting through those layers is not something that I have muscle memory of. It looks different on a simulator than in a real human. But that is something that's unfamiliar. And so, just sort of being careful of which layer we're going through is one thing that I learned from that experience.
Yeah, but even so, I mean, it's still making progress and you're still going there. As you keep going, you will hit water eventually. And
Water is the sign, right? The sign of life.
So where do we want to leave these wonderful people? They've seen this and everything. Where do we want to leave them today?
Well, I think obviously review the procedure. We've given you a little bit of demonstration here, and now it's on you to go through. Plenty of resources available for more education on this, but really the commitment to the procedure is the most important barrier to overcome. The reality that you're going to have to do this, and you're going to have to do it now, and it may be your first time doing it, and maybe you've only watched a demonstration on stage or a video on your laptop. But the commitment to the process is the #1 barrier, and then we move forward.
It doesn't have to go perfectly, and it did not. But let's remember why we're doing this.